Afternoon, everyone. So in this lecture today, what I'm going to cover is what is cancer epidemiology, just a brief explanation, and then some basic cancer statistics. And then I want to talk a bit about the main causes of cancer and the strength of evidence that there is for these, and finish off by talking through some of the most common types of study design that you'll find in epidemiology. So first of all, what is cancer epidemiology? So it's the study of the distribution, determinants, and frequency of malignant disease in specific populations. And the key here is that we're looking at populations rather than individuals. So for example, this might be studying trends and frequency of cancer in a given population, identifying the causes or risk factors associated with developing cancer, and evaluating the impact of cancer prevention strategies, for example, screening. And as I said, the key aspect is that we're looking at events that occur in populations, not individuals. And what epidemiological studies do is they look at people who get a disease, but also look at people who don't get a disease, and they want to look at how those two groups may differ. For ethical reasons, the methods used are predominantly observational or non-experimental, because we can't randomize people to these exposures. And this differs from clinical medicine, where patients are randomized to clinical trials and they're given either drug A versus drug B or a treatment versus placebo. And so a key challenge for epidemiologists is to try and identify and make use of natural experiments that that kind of akin to the sort of randomization you get in trials that can help answer the questions. So you might find that something's happened to one population and then you want to compare to a different population. So I'm just going to move on to talk through briefly some cancer statistics, starting with the UK. So between 2016 and 2018, there were approximately 375,000 new cancer cases each year. And 4 main cancers account for over half of all new cases. So that's breast, prostate, lung, and bowel cancers. And the incidence rates for all cancers combined are increasing year on year. And this is partly due to our improvements in the detection of cancer, and partly due to the aging population and people surviving for longer, and the fact that cancer is more common in the older ages. And so this graph just demonstrates that. So here we have age at diagnosis along the x-axis and the number of cancer cases per year on the y-axis. And we have blue for males and pink for females. And you can see that the number of cases is quite low until you reach about the age of 50. And then you see a huge increase. And in fact, the kind of most common age for cancers to be diagnosed is around age 80. Looking at the most common, the types of cancers that are diagnosed, this data comes from the National Cancer Registration Service, and they capture information on all new cancer diagnoses each year. And it's really high quality and complete data. And so you can see, as I mentioned, the top 4 there, so prostate, breast, lung, and colorectal. And then you can see the distributions of the other types of cancers. So getting down to the very rarer ones at the bottom, like testicular cancer and larynx cancer. In terms of survival, we have seen really, overall, we've seen really good improvements in survival. So survival has actually doubled in the last 40 years in the UK, but this hasn't been across the board for all different types of cancer. So the graph here shows the changes in survival over 40 years. And we can see for some, for example, prostate, there's been huge increases in survival rates. So survival was down at 25% and now is much, much higher. But we can see at the bottom of the graph, for example, for lung cancer and pancreatic cancer, there's been very little change in survival rates for those cancers. in the 40 years. And so this is a real challenge for clinicians and researchers. As well as looking at the kind of traditional measures like survival, it's been increasingly recognised that we need to look at the group of people who've survived or are living with cancer. And this is an ever increasing group as more and more people survive their cancer and are living after their treatment. And people can have quite significant side effects after a cancer diagnosis and treatment. This might be physical side effects or emotional or social. And it's a real challenge to the NHS and the kind of wider care system to provide adequate care and the services that these people need after cancer. Just want to very briefly mention the global picture. So both cancer incidence and mortality are rapidly increasing worldwide. And the graph that I'm showing here on the left-hand side, it just highlights the most common cancer diagnosed in each country. And on the top, this is for males, and on the bottom for females. So on the top one for males, we have lots of greens, which is prostate cancer, and blues, which is lung cancer, with a few other differences in there. For example, liver cancer is very common in some areas in Asia. And for the females, we can see it's predominantly pink, which is breast cancer being the most common cancer. And the orange is cervical cancer, which we see in a lot of African countries. But what this doesn't show is the differences in survival from these cancers. And these will really vary across the globe. And a lot of it's to do with the level of industrialization and development of the countries and the healthcare systems and the treatments that are available. In terms of mortality, because of the increasing population and the fact that the population, most populations are surviving to older ages, we're going to see a massive increase both in incidence of cancer but also in deaths as well. So worldwide cancer deaths are projected to increase from 10 million to 16 million by 2040. I'm going to move on now to talk through some of the most common causes of cancer. So the causes and risk factors for cancer vary according to the type of cancer, but the most common ones include tobacco. There's lifestyle factors, for example, alcohol, diet and obesity, occupational exposures, environmental exposures, infection, and also genetic predisposition. And I'm just going to talk briefly through the evidence and the kind of changes that have been seen in these over recent years and around the globe. Firstly, just share this graph, which shows in the UK the percentage of cancer cases that are attributable to various different exposures. And we can see that tobacco smoking by far accounts for the most cancer cases. And this will probably be the case in most countries. But we can also see that the second highest is overweight and obesity, and then we have radiation, occupation, infections, and so on. And a lot of these are actually preventable. So if we were able to improve people's diets, reduce smoking, etc., we should be able to reduce some of these cancer cases. So I'm going to start with looking at tobacco. So I'm sure everyone knows that smoking is one of the biggest preventable causes of cancer. And the link between smoking and cancer is really very clear now. It causes at least 15 different types of cancer, and not only lung, but causes mouth cancer, pancreatic, kidney, bladder cancer. And it's estimated that smoking causes around 7 in 10 lung cancers in the UK. So this graph here shows excuse me, trends in tobacco consumption in the US, the UK and Canada. And the patterns in all three countries are fairly similar. So since the 1920s, you can see that smoking really increased rapidly. and it reached a peak in about the 70s and 80s. But since people realised the harms associated with smoking, rates have come down quite rapidly. But if we look at this alongside the lung cancer death rates, it's a really interesting picture. So this is an example from the US. So the blue line is the cigarette consumption, as we just saw previously. But now we have the male lung cancer death rate in the red line and the female lung cancer death rate in the green line. And you can see, particularly for the males, how it really mirrors the tobacco consumption, but just with this lag time of around 30 years. And we don't see this quite the same striking effect for the females, but that's because smoking wasn't sort of taken up to quite the same extent, or was taken up later by females. And so you don't see that the lung cancer cases for females are starting to come down to the same extent as you do for males. And we can look at this in the UK as well, and there's a very similar picture. So this one here is looking at lung cancer incidence rather than mortality, but it's a similar story. So we have smoking prevalence in the solid lines, blue for males and pink for females. And then the dashed lines is lung cancer incidence. And again, for males, you can see that the lines really track each other with just this lag time. And for females, we can see that smoking levels have come down, but not to the same sort of relative extent. And we're not seeing that decline in lung cancer incidence, but we are seeing a plateau. And so it's hoped that this will start to decline in the next few years. Just want to briefly mention e-cigarettes. So in 2019, around 7% of adults reported using e-cigarettes or vaping. And e-cigarettes are used almost exclusively by smokers or ex-smokers trying to quit. And research to date indicates that vaping is less harmful than smoking, but as this is quite a new thing, there isn't any definitive long-term proof of safety. But so far, it shows that there's no increase in the risk of cancer. Moving on to look at alcohol consumption. It's estimated that alcohol is involved in the development of about 3% of all cancers, slightly more in men than in women. And looking in women, approximately half of these cancers are breast cancers that can be attributed to alcohol. So there's several cancers that are linked with drinking alcohol. So particularly those around the mouth and throat, and also the esophagus, and breast cancer is a big one for women as well, and also liver. And how does alcohol cause cancer? So there's a variety of ways. So it can damage DNA and proteins. It can form toxins, which can be particularly bad for the liver. It increases estrogen levels, which is why we see this breast cancer risk increase in females, and can also lead to poor nutrition by nutrients being blocked. And as a result of this poor nutrition, obesity risk increases, and that can then increase cancer risk even further. Many people don't really know what a unit of alcohol is, and so accurately measuring alcohol consumption is difficult. I'm sure many people know that if someone asks you, or if your doctor asks you how much do you drink, you know, always maybe underestimate it, and it's whether that's, people might do that on purpose, or a lot of people just genuinely don't know what a unit is and just don't think that they drink as much as they do. And so it can be really difficult to accurately measure this. I'm going to talk a bit about diet now. So again, establishing the exact effects of diet on the risk of cancer has proved challenging, but there is now some strong evidence for some factors. So one of these is looking at foods that have been preserved with salt. So Nasopharyngeal cancer, so cancers of the nose, mouth and throat, are really common in a few populations around the world. For example, populations in southern China and some indigenous populations. And it's been found that eating foods that have been preserved with salt is very strongly linked with these cancers. And there's the International Agency for Research on Cancer, or IARC, and they've done a lot of work over the years in identifying and classifying carcinogens. And they have classified Chinese-style salted fish as a carcinogen. Another one that's more recently been sort of found to be a cause of cancer and been classified as carcinogenic is processed meat. So studies have shown some striking correlations between eating red meat and colorectal cancer rates. And it's been kind of definitively shown that processed meat, such as sausages and hot dogs, bacon, are associated with colorectal cancer. And also that red meat more generally is defined as probably causing cancer. In terms of dietary fibre, this is associated with a reduction in colorectal cancer risk. But further research is needed because analysis suggests that this can be due to some whole grain cereals, but not fibre from fruit or vegetables. So it's not entirely clear what the mechanisms are there. The human diet is complex. It involves a mixture of nutrients, foods, different preparations and practices. And so this makes it complex to measure. And one of the standard approaches that we use is to ask people what we eat. And this is in the form of a food frequency questionnaire. So it's a really long list of food items, and participants check off what types of food they eat, how often, and the portion sizes. But obviously, people might not be that great at remembering what they've eaten. They might forget, or they might deliberately misreport. And so these methods have been criticised for being inaccurate. People may particularly omit certain more fatty foods or desserts. And so researchers are trying to come up with some more accurate measures of diet. So, for example, looking at markers in urine or other, or in blood, whatever. But in terms of being able to measure it from a large number of people, I think the food frequency questionnaire is the best one that we have at the moment. Moving on to look at obesity. So it's estimated that around 28% of adults in England are obese, and a further 36% are overweight. And you can see from this graph that this is slowly increasing over time, and has probably continued to increase since this graph goes up to 2018. And a range of cancers are thought to be associated with overweight and obesity. So you see from this figure here a huge range of cancers from meningioma to esophageal, ovarian, colorectal, etc. And nearly all of the evidence that links obesity to cancer risk, it comes from these large cohort studies. So that's a type of observational study, which I will talk a bit more about later. But the data from these studies can be difficult to interpret and cannot necessarily definitively establish that obesity causes cancer. So it may be that obese or overweight people differ from lean people in other ways apart from the body fat. And it's these factors that are maybe explaining the difference in cancer risk. And this is what we call confounding factors. And so a challenge for epidemiology is to try and establish and account for as many of these confounding factors as possible, so that what you end up with is a difference that can be accounted to obesity in this case. But despite these limitations, there is now consistent evidence that higher amounts of body fat are associated with an increased risk of a number of cancers. I'm going to move on now to look at environmental exposure. So firstly, looking at asbestos. So this is a naturally occurring fibre that was widely used in the construction and other industries until the late 90s. And asbestos cancers are caused by inhaling or ingesting these fibres, and they can embed in tissues and organs, and over time they cause inflammation and mutation cancer. Most often, asbestos cancer refers to mesothelioma, which affects the lining of the lungs, but it can also cause several other malignancies. Just looking at mesothelioma, unfortunately, this cancer has a really poor survival rate. So average survival time after diagnosis is only 12 to 21 months. And the good news is that because we're now more aware of this, and asbestos has been removed from the majority of buildings, and the exposure is a lot less, we are seeing now a plateau in the incidence of and mortality from mesothelioma. And this graph here just shows that this is projected to decline quite considerably. This graph goes up to 2035, and if these patterns become, are realised, then this should carry on declining over the years after that. And so hopefully this will become a very, very rare cancer. Another one to look at is air pollution. So outdoor air pollution is a mixture of tiny dust-like particles, and this comes from fumes and smoke from burning fuels. And in 2013, IARC confirmed that outdoor air pollution is a carcinogen, and that some of these really small particles have been linked to some types of lung cancer. However, in the UK, we have really fairly low levels of outdoor air pollution compared to other countries, and so it's not really such an issue for us here. But if you can just look at this figure here, this shows that this striking variation that there is around the globe. So this is particulate matter air pollution. This was in 2016, but I would imagine it hasn't changed that much. So across America and across Europe, you can see really low rates, which is the kind of pale colours. But where we see the oranges, the reds, the really dark reds, this is really high levels of air pollution, and this is going to be contributing to a fair number of cancer cases. A third environmental exposure to look at is UV radiation. So this is a form of electromagnetic radiation that comes from the sun. So there's two main types. There's UVA rays. These rays cause skin cells to age, and they can cause some indirect damage to the DNA. And then there's UVB rays. These have slightly more energy than UVA rays, and these are the ones that can damage the DNA in cells directly, and the rays that cause sunburns. And these are the ones that are thought to cause most skin cancers. This slide here shows the sort of main common types of skin cancer. So the most common are basal cell and squamous cell cancers, and these tend to be found on the sun-exposed parts of the body. So, for example, the arms and legs, or you might commonly find them on the torso in people who work outdoors a lot. And the occurrence of these is typically related to lifetime sun exposure. There is another type of skin cancer, that's melanoma. And this is less common but more serious type. And whilst it is also related to sun exposure, it's not as strongly related. And there is also a genetic element to this, a familial element. And I'm sure you're all aware that skin cancer has also been linked to some man-made sources, such as tanning beds. I just want to briefly mention occupational exposure. So this most often involves the lung, so people breathing in breathing in various fumes or really small particles from like metalworks or something. But other sites affected can include the skin, the urinary tract, and the nasal cavity. Most occupational carcinogens have been eliminated from the workplace, especially in the sort of more developed countries. However, in some countries, these do still pose a significant health risk. I'm going to move on to look at some infectious factors now. So it's estimated that worldwide infections are linked to 15 to 20% of cancers. And this percentage is higher in developing countries and lower in developed countries. Some examples with strong evidence include Helicobacter pylori causing stomach cancer, hepatitis B and C causing liver cancer, Epstein-Barr virus and Burkitt's lymphoma, HIV and sarcoma, and so on. Just today, I just want to mention one, which is HPV and the links with cervical cancer. So human papillomaviruses, or HPVs, are a group of more than 150 related viruses. And some of these cause papillomas, or more commonly known as warts. But there are a few types of HPV which have been found to be the main causes of cervical cancer. And as well as cervical cancer, HPV also has a role in causing several other cancers. Cervical cancer has become much less common in developed countries because of the Pap test, or the smear test, which has been available for many years. So, for example, in this country, we've had the screening program for a fair while now. And this test detects precancerous cells in the cervix, which can be destroyed or removed, and they don't then go on to develop into cervical cancer. In the UK, the HPV vaccine has been started to be offered to girls since 2008, and this was extended to boys in 2019. And this vaccine is still relatively new, and so we won't know the effect on the rates of cervical cancer until those who receive the vaccine are older. However, the data is looking really promising. So studies looking at the percentage of women diagnosed with abnormalities have shown a marked reduction since the introduction of the vaccination programme. And this graph here shows the changes in the HPV prevalence after vaccination in 16 to 18-year-old females, so those who would have been vaccinated a few years before. And you can see from this graph that as the vaccination coverage increases, so that's at the bottom of the graph, so starts from 60% and goes up to 84%. As the vaccination coverage increases, we can see this really striking decline in the HPV prevalence. And so it's a really promising evidence that this is going to have a significant effect on cervical cancer rates in the future. Moving on to look at genetic predisposition. Some people have inherited gene faults that increase their risk of developing particular types of cancer. And it's thought that inherited syndromes may account for up to 4% of all cancers. And there are tests available for some of these gene faults, but not all of them. I'm just going to go through a few examples now, starting with breast cancer. Researchers think that around 5 to 10% of breast cancers are caused by an inherited faulty gene. And there's several genes that do significantly increase the risk of breast cancer and that can be tested for, including BRCA1, BRCA2, TP53, and others. And similarly, for ovarian cancer, it's estimated that around 5 to 15% of women with ovarian cancer have a faulty gene. And in most cases, this is also related to a faulty BRCA1 or BRCA2 gene. And so family members who with a faulty BRCA1 gene have a greater than 70% lifetime risk of developing breast or ovarian cancer. And this is why some women take the decision to have a prophylactic mastectomy or to have their ovaries removed, because they know that they have this really high chance of developing cancer in their lifetime. Another example is Lynch syndrome. So this is caused by faults in a variety of genes, and it's been linked to the development of bowel cancer at a very early age. So Lynch syndrome accounts for about 3% of bowel cancers, but most of these occur at a much younger age than you would normally see bowel cancer being diagnosed. So under the age of 50, which is really young, normally you would see it in sort of 70s or 80s. Screening has recently become available for Lynch syndrome, and I think this is sort of more commonly being taken up by people. As well as colorectal cancer, Lynch syndrome also conveys a risk of developing other types of cancer. And for women, there's quite a high risk of developing womb cancer as well. And finally, just to mention melanoma, as I said earlier, melanoma also has a familial concept. So around 1 in 10 people who have melanoma have a strong family history of the disease. And there is a particular syndrome, so FAMMM, which increases the risk of developing melanoma. And people with this syndrome have over 50 moles and at least one close relative diagnosed with melanoma. And researchers have found genes that are associated with this syndrome. I'm just going to finish by talking through some of the most common types of study design that are used in epidemiology. So there are different ways of carrying out epidemiological studies. As I said before, these are observational studies. So randomized control trials are where people, these are experimental studies. People are randomized to different arms, but we can't really do that in epidemiology. So we conduct various different observational studies. And I'm going to talk through the sort of 4 main ones that are listed here. Firstly, looking at ecological studies. So in this type of study, the unit of observation is the population or community. And disease rates and exposures are measured in a series of populations, and then their relationship or their correlation is examined. And often this doesn't require any sort of detailed data collection, because the information about the disease and the exposure can be taken from published statistics. The drawback of these studies is that you can only ever imply a correlation and not a causation, but it can give some indications of things that you might want to sort of investigate in more detail. And the measures of exposure are only ever a proxy based on the average in the population. And so you need to be really careful when trying to apply the results to the individual level. And this is something that we call the ecological fallacy. An example of a ecological study is given here. So we have per capita daily meat consumption in a variety of different countries, and along the y-axis we have colon cancer incidence. And you can see that here you get a really nice striking, nice straight line, nice correlation, whereby the higher the daily meat consumption, the higher the rate of colon cancer incidence. But you can also end up with some kind of spurious correlations, and this is just a silly example I found, but you have margarine consumption across the bottom and the divorce rate in Maine on the y-axis, and a wonderfully strong correlation, but obviously it doesn't mean anything. So it's just a kind of note that you have to be careful with this type of study, as you can only ever get a correlation and not causation. Moving on to cohort studies. So this is kind of one of the main types of studies that you see in epidemiology. So this is where you recruit and follow participants who share a common characteristic. So you might take people who work in a particular occupation, or take people from a particular demographic part of the population. So you might look at all women of a certain age, and then you follow them up, and over time, some of the cohort will be exposed to specific risk factors. And you can measure their outcomes over time and explore the impact of these particular risk factors that you're interested in. So you might look at the impact on the development of disease or on mortality. But there's lots of challenges to this type of study. So if you're wanting to collect data on thousands of participants over many years, sometimes these studies go on for decades. It's really time consuming, it's complex, and it's very expensive. And you need to be careful about participants dropping out, and you might find that, for example, older people may drop out more, or those from more socioeconomically deprived areas drop out more. And so you can increase the risk of bias as time goes on. And equally, it's possible that people change their behaviour because they know that they're in a study. An example of a cohort study is the British Doctors Study. So in the 50s, various researchers wrote to all registered doctors in the UK to ask about their smoking habits. And this study recruited and followed up over 40,000 participants, looking at mortality rates and causes of death. And even within the first few years, when they got the first preliminary results, there was strong evidence that was linking smoking with lung cancer and increased mortality. And over the following decades, this study provided really definitive evidence of the health risks from smoking. Another example of a cohort study is the Million Women Study. And this has recruited 1.3 million women aged 50 to 64. And these were recruited through the breast cancer screening centres between 1996 and 2001. And this sample equates to 1 in 4 of all UK women born between 1935 and 1950. And this study's published loads of papers, but some of the key things that they've found is that they've identified increased risks of breast, ovarian and endometrial cancer associated with hormone replacement therapy. And I just wanted to highlight the MRC National Survey of Health and Development. So this is the world's oldest continually running cohort study. And this was looked based on a selection of births which occurred in England, Wales and Scotland during 1 week in 1946. And these individuals have been followed up continually since and followed up at 25 time points. The kind of opposite almost to the cohort study is the case control study. And so this is where you start with people who have developed a disease, and then you look back at their past exposure to suspected causes and compare that with a group of controls who don't have the disease. So one of the most complex things here is selecting your controls and getting them to be representative of the population at risk. For example, you might want to take them from general practice registers, and you can match on key factors. So you might match on age and sex to try and make sure that your controls are as representative of your cases as possible. Exposure in these cases is often measured from personal recall, might be using a questionnaire or an interview. And so an obvious limitation is recall bias. You might be asking people to remember things that happened more than 10 years ago. And if it's something like dietary habits, you can see why that might not be very reliable. And so what researchers would do, if possible, is try and extract this exposure data from existing, more reliable sources. So you might be able to look at hospital records or GP records or some other source of data. So just to highlight these two types of study and their differences. So the cohort study, this is where you're following up a cohort over time and looking at the outcomes in the future. Whereas the case control study is where you're looking back, you have people with a disease and you're looking back at their previous exposure. The final type of study I want to highlight is a cross-sectional study. So this is where you measure the prevalence of specific health outcomes in a population at one specific point in time. You can then repeat this at multiple time points and look at the trends over time. So, for example, the census is a type of cross-sectional study, as it's looking at a snapshot of the population every 10 years. The associations you find here, again, must be interpreted with caution. So you can't really define causation here. You haven't got the timing of when things happen. So you can't say what is a cause and what is effect. But they can be really useful in understanding what's happening in a population at a given time and over time. Just to briefly touch on the types of data that you might want to be collecting in an epidemiological study. So there's two main types, primary data and secondary data. So primary data is that you collect yourself, real time, detailed, very involved, and can be expensive. And this might be surveys, interviews, biological measurements. Whereas secondary data might be that's been collected by another study, or it's from existing records like hospital records or case notes. And so this is less detailed, but it's quick and easy, and it's a lot cheaper. And the types of data that you want to collect, it depends on your study aims, the resources that you have available, the staff you have, and the time frame that you have to collect your data. So those are all the sorts of things that you need to consider if you were designing a study. And I just want to finish by just highlighting these sort of key points that make up what you would be looking for if you're either designing an epidemiological study or if you're appraising one or reading one. And I think these just kind of give a nice summary of some of the main points that I've been trying to get across today. So firstly, the aim of any study should be really clearly stated. It should be able to easily understand what they want to do and be able to appraise whether they have actually achieved that or not. Any sample that's included in a study should accurately reflect the wider population from which it is drawn. So you wouldn't want to just include men of a certain age in your study and then try and say that it's representative of everybody. Entry criteria and exclusions should be stated and justified, and the number of patients lost to follow-up should be stated. So patients may drop out of studies, as I mentioned earlier. You may find you get differential dropout. Patients may die, patients may move house and you can't contact them. There's all kinds of reasons that patients are lost, but it can have an effect on bias in the sample that you end up with. If you're having a control group, then the source of any controls needs to be explained, and you need to know whether these controls are whether they're a good match to your cases, and also has there been any matching or randomization. So as I said earlier, you might want to match your controls and cases on age and sex to try and make them as comparable as possible. Can the results be repeated, or is there a reason to suspect there may be a one-off? So if you've got a poorly designed study that finds some magical new result, then it's highly suspicious that this could actually be repeated in a much better, well-designed study. Missing data, how much is missing, why? Again, this can lead to bias in the results. Could any other interventions have affected some but not all of the subjects? So you need to make sure that you're accounting for all of the kind of other factors that may have affected the outcomes. And this is related to the confounding factors. So you need to identify all of the other variables that might be influencing the results and try and account for as many of these as possible. It's not always possible to get the data or to be able to measure every single factor, but you need to at least be aware of them and acknowledge that they are there and that they may be having some influence. And just finally, are the results of the study generalizable to other populations? So if you studied patients in one hospital in Leeds, you wouldn't necessarily be able to say that these are generalizable to, you know, the whole UK or to other developed nations. And so that's where I'll stop for today. Thank you.
Thank you very much, Amy. If you can unshare your screen, please.
Yeah.
Okay, thank you. Thank you very much. We've got, I think, 5 or 10 minutes to take questions from the floor. Is there any questions? I've got a couple of questions, kind of, Amy. The first one is that you showed that graph at the beginning, near the beginning of your study, where you talked about factors that affect cancer, and obviously smoking's up there, but then you get a whole raft of ones that are about the same value.
Yeah.
You know, what is the kind of, you know, what is the errors on these kind of percentages, these factors?
It's a good question. I mean, off the top of my head, I'm not sure. It might have been in that paper, but I think for some of them, the errors might be quite large, because as I've emphasized quite a lot, measuring some of these things is really difficult. And so, and the, you know, the ways that these things would be measured would be quite different. For example, you know, you're looking at measuring air pollution compared to, you know, contraceptive use in women or something. They're really very different. So yeah, how comparable they are and how much error there is probably quite variable depending which one you're looking at.
A second question is, you work with these large data sets, and these data sets come from different sources. You know, some will be from specific studies, maybe other ones from GP records or hospital records or whatever. How big of a challenge is it to make sure those data sets, first of all, you know, you can merge them together and, you know, and do studies on them? And secondly, what is the error rate in these? You know, I presume you check the data of these kind of large hospital records, and we know that people put the data in manually in some occasions. And what sort of error rates are you talking about within these data sets, and how do you check them for their kind of authenticity? How do you verify these data sets?
So the data sets that I tend to work with are, you know, things like national cancer registration data and hospital admissions data, which they're actually, you know, very complete. So you can be pretty sure that for cancer registration data, you can be pretty sure that you are picking up all the cancers that you're capturing. But then within that, some of the data is better recorded than others. So, you know, things like age and sex is really, really well recorded. But if you look at something like ethnicity, that it's got better over time, but that used to be really poorly recorded. And you could see in the hospital data that people changed their ethnicity over time, which is, you know, it's just nonsense. And so you have to come up with methods of harmonizing that data. Some data sets, you know, you will know that you're missing big chunks of the population, but for the ones that I tend to work with, we do know that they are pretty much population covered. But you just have, I guess, it's you get to know it as you work with these data. So things like stage at diagnosis for cancer is one. So the cancer registry staff, they take this information from like pathology reports, and you can find that these vary at different hospitals, vary for different cancer sites, different pathologists. There's so many factors. But the good news is that generally recording of these things has got better over time. So the data is getting better.
Is that because protocols are put in place and things like checklists and things like that?
Yeah, and things are becoming more, you know, the systems have improved. Things have been, you know, mandated to be collected. For example, in like GP practices, there's certain things that they get paid to collect, so they suddenly become really well collected.
Okay, and finally, you know, everybody's talking about AI and machine learning. What can I, you know, what impact has this had on epidemiology, or what impact do you think it having in the near future?
Oh, good question. So I mean, most of the AI sort of things that I'm aware of is more to do with like analyzing images of, you know, CT scans or something like that. But in terms of epidemiology, I'm not sure. So I am involved with the CDT that we have here in Leeds and supervise a couple of students. They're looking at patient reported outcomes. So, you know, I mentioned about looking at the quality of life of people after they've had cancer. We've done some survey work capturing the kind of issues that people have, and they had some free text boxes where people could write in additional information. It's always really, really difficult to analyze that sort of data. And so one of my students there is looking at different ways that AI can use that textual data and bring out themes from it. I'm sure there's loads more going on, but it's not an area I know that much about.
Okay, thank you very much. Is there any, before we close, are there any further questions from the floor? I think you've blown them all away, Amy. So thank you very much for the presentation. That was most insightful.